Our next speaker is Dr. John Carroll from Denver here. This topic is translating the echo to fluoro and back. Dr. Carroll.
Okay, well, I'm here. So Jackie, Matt, that's fine. I can look up there. So I redid this talk last 24 hours after the Transseptal course that some of the organizers put on to try to articulate why I think image fusion really makes a lot of sense and helps us perform tasks, even something as basic as transseptal catheterization that, yes, you can do purely with X-ray guidance. So what is fusion? It's taking two patient-specific images and bringing them together, lining them in time. Registration is the process that's involved with aligning. And then how you display the resultant fused image is really specified by what task one is performing. And so this shows the two input data of the stream of fluoro data, the stream of 3D echo data, although it can be 2D and Doppler data as well that are fused together. And why should one even consider that in left atrial appendage? It's because, well, you use both modalities, and you want to perform a series of tasks in this procedure as efficiently as possible and as safely as possible, and kind of those are three of the basic tasks that are involved. And when you look at the traditional fluoro image, it's pretty dumb. It doesn't show anything about the soft tissues. It doesn't display the soft tissues that you're really working on. The septum, the left atrial appendage, the left atrial body, which you're navigating within. So wouldn't it be nice to make that live fluoro image more friendly, user-friendly, and smart? So when you think about doing transseptal, and I'm going to focus on transseptal because I think it's obviously the first key step in a lot of these interventions. And so you use fluoro and ultrasound for visualizing different aspects, but you use them quite separately. And used separately, you cannot efficiently and confidently answer the following questions if looking at the same. What is the relationship of the plane of the interatrial septum in the thorax? You can't tell that from a 3D echo. You can't tell that from a fluoro because you don't know where the plane of the septum is. Where's the soft tissue target in the fluoro image where you want the desired transseptal puncture? Well, you see it, you mark it on the echo image, but where is that in the fluoro image? And how is the IVC? Because that has another three-dimensional spatial relationship that can determine some of the complexities, and then you choose equipment to match the anatomy, but you really don't know the anatomy in terms of how the septum lies in the thorax, so you don't know what to use. So fusion allows you to do that, where you have on the fluoroscopic live image, live echo that you overlay and registered in time and space, so you can really see those structures. And so in the last couple of weeks, I've really noticed, and this is a schematic, of the relationship of coming up the IVC to the plane of the septum, thinking about the plane of the septum in very simplistic terms, whether it's more vertical or versus more horizontal. And there are a lot in the kind of transseptal patients we see today, a lot more anatomical variations. And why not start with the right needle bend for the right septal anatomy rather than some operators who say, well, I always start with that bend, and then when it doesn't work, I reshape it or I go back. That's inefficiency. If you knew going in where you're going to puncture and what the angle was, wouldn't you be a lot better prepared? I mean, just think of all the other interventional procedures and steps. We do the same sort of thinking. And here's the more extreme case from just last week down to that little yellow circles where I needed to make a transseptal puncture. And this was a very vertical heart. And so you barely needed any bend on the needle to reach that. And so if your standard default is to make a big bend and start with that, I don't know where that would have ended in this patient, but it would not have ended in the right place. So both modalities, live fluoro, live echo, are live, and therefore when they overlay, you get rid of some of the problems with them being malaligned if one's static and one's moving. And I'm not going to go into the details of how you could otherwise use it for the subsequent steps in left atrial appendage of navigating to the left atrial appendage. And this just shows how you can phase in, phase out the overlay of 3D TEE on echo. And the next generation is looking at taking the echo image, doing the automatic segmentation after you register the probe. Then you overlay the chambers derived from echo on top of the live fluoro. And that includes being able to do that with left atrial appendage and identifying automatically the os, the body, overlaying it. And so you can use, just like you'd use pre-procedure CTA sometimes to plan optimal fluoroscopic views, here you do it in the lab where you move the gantry and you can see how do I lay out the long axis of the left atrial appendage, the landing zone, what's the optimal fluoroscopic location, because the default REO caudal is not always the right ones. You like to tailor it for the individual patient. So in general, I think it makes sense that this technology is suitable for a procedure that is fluoroscopically guided, but is toward soft tissue targets, and it optimizes the performance of these different steps. Thank you.
Thanks, John. Wonderful overview here, and great images. You know, I think I can certainly see the advantages of having fusion imaging for these structural procedures. Can you just maybe highlight what is the potential additional cost, the hardware required, software required, additional time for getting these images?
Yeah, so it's really on a workstation. So it's software of inputting the two streams of live imaging data. And so the registration process is software-based, where it's recognizing the orientation of the 3D probe by the fluoro images, and that's a quite simple step to take. I really don't know the commercial cost of I think Philips is the only one with a commercially released system. I think both Siemens and GE are coming along with those. So it's a workstation-based cost. There is a learning curve. That's important. But it's ultimately, I think what you feel is that it really enhances the efficiency of procedures. As with new proprietary imaging technology, you can't mix and match one vendor's TEE with one member's X-ray system, and that I think is a limitation, but c'est la vie. Okay. Thanks.